All right, good morning. I'm Deb Stidham, and I serve as the chair of the Addiction Counselor Advisory Committee of the Kansas Behavioral Sciences Regulatory Board. I'm going to ask the members of the advisory committee to respond to a roll call to signify their presence at this open meeting that is being conducted remotely by conference call and other electronic medium. Jacqueline Lightcap.
Here.
Dina Boyd.
Present.
Jason Hetz.
Here.
Shane Hudson.
Here.
Chad Jacobs. Chad.
Yes.
See you. Yep, I hear you. Mike James.
Here.
No Charity yet.
That's correct. I don't see her on the call.
Okay, Dulcinea Rakestraw.
Present.
I note the following BSRB staff members are also present: David Fye and Leslie Allen. And now David Fye will read a message concerning this meeting being held remotely.
This is David Fye, Executive Director for the Behavioral Sciences Regulatory Board. Public comment allows the public to address the advisory committee about its concerns, but the Kansas Open Meeting Act, or KOMA, does not require the advisory committee to provide public comment or answer questions from individuals. Individuals requesting to provide public comment could contact the executive director prior to the meeting by sending an email to david.fye@ks.gov. One presenter from the Community Health Center of Southeast Kansas has been approved for 15 minutes, and presenters from the National Addiction Studies Accreditation Commission have been approved for 30 minutes. Because we are conducting this public meeting remotely by conference call and other teleconference ability, I state for the record the following information. Public access to this meeting is being conducted by a medium of interactive communication that allows members of the public without cost to attend the meeting through the use of the conference call and on the board's YouTube channel. While the meeting is conducted remotely, the requirements of KOMA are not suspended, so we will be conducting this meeting pursuant to the KOMA. On August 23rd, 2022, we sent notice of the advisory committee meeting to all individuals who had requested notice of the advisory committee meetings. The notice also was posted on the board's website at ksbsrb.ks.gov. You may obtain a copy of the notice at that website. An agenda and other media materials have been posted on the board's website, and you can request a copy of the agenda specifically by sending an email to david.fye@ks.gov with a subject line "request for the agenda," and it will be sent to you. The notice contains information for the conference call and YouTube channel that allow the members of the public to attend the meeting free of charge. The notice also states that if there are any technical issues during the meeting, you may call the board office at 785-296-3240 or send an email to bsrb@ks.gov. A recording of the meeting will be available on the BSRB YouTube channel following the conclusion of the meeting by using the link to the meeting on the agenda. And the conference call is live as well, so if I hear anyone beep into the conference call, I will let you know.
Thank you. The meeting is now called to order, and the advisory committee will begin its discussion of the first item. Has everyone had a chance to review the agenda and the other supporting documents that were emailed by David? Anyone have any changes to the agenda, or are we ready to approve it as written?
I move to approve, Deb.
Thank
I'll
you.
second.
Great. All in favor, say aye.
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 Any opposed? Great. We will go right into our guest speaker, Eric Thomason, who's going to present an idea for a new licensure type. Welcome, Eric.
And Eric, I believe you're muted right now.
I couldn't see him, so.
All right, sorry. Thank you very much for having me. I'm going to share my screen and just run through a PowerPoint quickly to make it a little bit easier for me to stay on topic and be respectful of your time. If I can pull it forward. Okay, are you guys able to see my slide okay?
Yes.
I'm going to leave it in this format, so I'm working off two monitors. But my name is Eric Thomason. I am a psychiatric nurse practitioner. I also serve as Director of Behavioral Health and Addiction Treatment Services for Community Health Center of Southeast Kansas. I greatly appreciate the opportunity to speak with you all today about some workforce shortage issues that we're experiencing here in Southeast Kansas, and I'm sure a lot of folks out there can appreciate addiction counselor shortages really everywhere in Kansas. Just briefly, a little bit about us. We're a federally qualified healthcare center. We really started in 2003 with an initiative to help keep kiddos in schools. We started out by offering primary dental care with dental hygienists and offering immunizations. We quickly grew to serve a very large amount of people, about 65,000 unique individuals in 2021. We have clinics operating in 9 counties in Southeast Kansas. We'll be adding a clinic in Garnett, Kansas for a 10th county. We also serve a couple places in northeastern Oklahoma. About 20,000 of our patients are Medicaid recipients. And if you look at behavioral health and addiction treatment services in particular, we had about 42,500 provider visits last year. And so we have a very large presence, not only for psychiatry and behavioral health in Southeast Kansas, we also do a lot of work with medication-assisted treatment. We firmly believe that medication-assisted treatment is something that should be implemented with counseling for all providers that are DEA waivered to provide services. We have to agree to an attestation statement that we will refer out to counseling. And so it's incredibly important for us as medication-assisted treatment needs continue to grow here in southeastern Kansas, that we have availability of counselors to do the work. On the right-hand side of this slide, you'll see kind of a map, and don't get lost in all the numbers in different colors, but just know that the dark purple area signifies where 75% of our patients come from. And so you'll see folks that come up from Oklahoma, over from Missouri, of course, a large presence in where we have our physical locations in our clinics. The next map kind of signifies where exactly we've got our locations and where hopefully we're headed. One thing as a federally qualified healthcare center that makes us a little bit different from some of our community partners is we offer multidisciplinary treatment. And so we have primary care services, radiography, diagnostics, internal medicine, specialty care, pharmacy, dentistry. So each little red star or orange star represents a location where we have a clinic. The old nursing caps, if you'll think back to nursing, is where we have our school-based nursing staff. Our green ribbons are where we have school-based behavioral health providers. And these little boxes that aren't coming through very clearly are where we actually have health clinics located. And so these are multidisciplinary clinics located inside school districts. These large green stars are where we hope to eventually be one day, because we're seeing a lot of folks from those areas. This comes as no surprise to the individuals on the call. Kansas really struggles with access to healthcare providers. And so the bottom picture represents dark blue is not a good thing. We don't have enough providers to go around to help meet the needs. Specifically talking about addiction treatment, and I sent this in the document prior to this meeting. I got a report from the BSRB around June 1st of 2022. At that point in time, we had about 1,551 addictions counselors that were on your mailer list. So what I did was I went back and I looked and tried to find how many of them actually lived in our service area. So the 9 counties that we serve here in Southeast Kansas. And despite representing about 6% of the population, we only have about 4% of licensed addictions counselors that call this area home. Not all of those folks, of course, are practicing. Not all of those folks are working in addictions. And so we're already short just from how many people we should have living here, right? We should have 6%. And so the challenge for us is how do we continue to support the need that's identified in our communities? And so I've been spending a lot of my time over the last 4 years as I've been the director trying to figure out how do we recruit, retain, build upon the addiction treatment staff that we have currently. I ran into a situation earlier this year where I was having multiple applicants apply to be an addictions counselor with us. They weren't certified at the time. They were just finishing school. And so I would visit with them about what courses they've taken and do they meet criteria for examination. And unfortunately, what I have found is that we have several folks who are leaving universities with a bachelor's degree in psychology in particular, or social work, and they haven't taken the required coursework to be eligible for examination through the BSRB. And so when you look at, and this was pulled directly from your website, when you look at the courses that are required to sit for certification examination, you'll see for our licensed bachelors of social work, they have to have an introduction to addiction pharmacology, and practicum that doesn't have to be addictions specific. We look at our bachelor's degree in psychology. Of course, we've got introduction to addiction pharmacology, addiction services coordination, practicum that is addiction specific, and co-occurring disorders. And what I did from there is I went and I pulled the program information from Pittsburgh State University, which is a Division II university here that teaches a lot of our folks and does a spectacular job. Several years ago, they discontinued their addiction specific degree in psychology due to lack of enrollment. And so what has happened, and what we're seeing in other rural areas of Kansas, is that we have some academic institutions that don't even offer the coursework required to test. Or we have folks who go to, like I had an applicant who went to Emporia State, got a bachelor's degree in psychology. Courses were available to them, but they didn't take them, and applied for the position wanting to be an addictions counselor, but was ineligible to test. And so then the conversation that I have with them is, hey, I know you just finished your bachelor's degree, but you have to go back and take additional courses. And I'm like, well, I can't. Some of the financial aid that I have available to me doesn't count anymore because I'm not a degree seeking student going back and just getting a couple extra courses. And so really a lot of these folks are faced with two things. One, don't enter the addictions world as a counselor, or two, go get a master's degree, or three, go back and take courses. And it's disheartening. I've had this conversation probably about 10 times with folks throughout Southeast Kansas over the last 6 months. And I'm hoping that maybe we can. So I dove back a little bit. I found this position that was called an associate's counselor. I tried to find it under current statute. As all of you know, that doesn't exist anymore. And so my hope is to stimulate a conversation about adding another level to addictions counselors. Our neighbors in Missouri have multiple levels. That doesn't mean that what they're doing is necessarily correct. But one of the challenges that we face from a recruitment perspective is we have no entry level addictions counselors that are coming to us. Most of them are dual licensed, which means they have a behavioral health credential plus an addictions credential, which means that we pay them more, rightfully so, that they've got experience in behavioral health services. And a lot of them still make more being behavioral health therapists versus addictions counselors, so they don't enter the addictions field. And so I'm hoping that we can do something with the folks who have a bachelor's degree in social work or a bachelor's degree in psychology, but are just short a couple classes. Or folks who got a bachelor's degree in psychology and took a practicum that wasn't addiction specific. And under the supervision of a licensed clinical addictions counselor at a KDADS approved addiction treatment site, that they be able to receive credit for practicum hours or supervision hours that would eventually make them eligible for full licensure and examination. One route would be a provisional licensure or temporary licensure that would 18 months, 24 months, that would give people an opportunity to seek it, be approved for it, continue their coursework while practicing in the field. And we're currently doing that with some of our addictions, some of our LBSWs who are working with us as community health workers. It's just challenging and they have a heart for the work, and I'd love to get them to do it. So I'm more than happy. I want to be respectful of your time. I sent some statistics and some data in the letter before this meeting, kind of supporting the need for additional counselors. Does the advisory committee have any questions, concerns, or anything that you guys would like to know from me or my experience in Southeast Kansas?
Committee?
Thank you for providing this information. I find it really helpful.
I've actually been a part of similar conversations that are happening here in South Central Kansas. I live in the Wichita area. And we've actually had some pretty large scale conversations along these same lines. Maybe considering coming at it from a different way, but this is certainly something that's important to be considering. So thank you for pulling all of this together.
You're very welcome, and I appreciate the opportunity to speak on it. I know there are a subset of people who want to enter the addictions field, and they're hard to find to begin with. But through no fault of their own, through no fault of the academic institution, they're short a couple classes. And so having an intermediary way to get them into the field would keep them there. And then they can build from that. If they want to go get a master's degree, if they want to do additional things, that's wonderful. But people who are interested in doing the work now, I'd love a chance to get them in the field under the supervision of a clinical addictions counselor.
Go
Go
ahead, Michael.
I was just going to speak a little bit to, I clearly know exactly what you're talking about, and my other half of my job is working in community college land, and I'm the only one, it's the only college that has any of the addiction courses anymore at the community college level, and that's because of the changes in licensure. So I would say, bringing this here, absolutely, good idea. And then if this moves forward, you would probably also want to be voicing against this opinion with the education side of the house too. Because as many of you probably are aware, they're looking to downsize higher ed as well in many ways. So specific things like addiction, it's hard for colleges to offer those courses when it is these small numbers, really hard with these small numbers. Can't say Kansas is, I've been lucky to have been able to maintain it here. The numbers are significant to the field, but definitely not as large and as robust as they could be.
Michael, and to build on that, I had a really interesting conversation with Purdue Global. So Purdue University, they have a very robust online training platform, and they had mentioned how they needed practicum sites for addictions folks. And that kind of got me thinking, I'd love to keep money in Kansas and partnering with local institutions. And we do this a lot with other specialties like KU, Wichita State. Heck, we've got a pediatric dental residency with NYU. So, but anything we can do to help support academic institutions to refer applicants or partnerships to help get folks appropriately trained, CHC is more than happy to help do that work.
I think something that I've seen as a double-edged sword is that I appreciate all the requirements for counselors in Kansas. That's good because we hold people to a high level. However, when we've seen a couple applicants, I think in the last year, try to come in from other states who've been practicing and doing the work and doing good work, whether it be at the master's level, whatever exists in their state to do therapy, or as an addiction counselor, and whatever it's called in their state to practice as an addiction counselor. They miss something, and it typically feels like a small thing around educational requirements and things like that. And it's kept us from hiring a couple of people. So I think something just to consider, how do we get our workforce really strengthened with people who want to be here, but there's something that causes a hiccup in that process that I don't view as a big thing, but I understand there's some black and white pieces that aren't lining up perfectly. And I'm guessing other providers have some examples of that, but it just sticks out in my mind as something I wish was a little bit different in some way.
Yeah, Shane, and to build upon that point, I had an opportunity to speak to the Kansas legislation regarding modifications to social work requirements for reciprocity. And they made some changes, I think it was about a year or 2 years ago, that significantly improved our ability to, one, stop losing folks to Oklahoma or Missouri, and two, to start recruiting folks from Oklahoma, Missouri, or other states into Kansas. And so the BSRB and the legislation team have done a great job from there. So I just didn't know if this was something that was brought up or thought about. And I greatly appreciate the requirement of a bachelor's degree. I support that 100%. I do not want to water down the profession or produce unprepared clinicians. I just want to try to find a way to capture the people who are interested.
So Eric, I love that you're looking at this as a way to move forward, that we're going to have to get creative because the workforce issues are affecting everybody really across the state, and to a level that is hard to even describe. I think for many agencies, I don't even know what words you can put to it when you've had positions open for years and years, and it absolutely is going to affect the current workforce as well as the outcomes of those that you're providing treatment. I'm wondering with this, I mean, just thinking completely outside the box here, looking at different levels of licensure, and then is there any talk of that, of how that could maybe relate to different levels of services and billing? Because I do think, as we've talked, like there is a certain level of competency that we would expect maybe at that master's level to be able to really provide certain therapeutic interventions because of the complexity and the acuity, honestly, of individuals that are coming through the door, and based on research evidence that really a large majority of folks that are dealing with addictions or substance use also have mental health issues and all those other things that become then very complex. And so I'm wondering, again, being in that, I was in community mental health for a number of years, my brain immediately went to like case management type services and those kind of billing codes that became very important. And those services, I worked as a case manager for a number of years at the bachelor's level, and then was able, then I made my decision to go back, get my master's, kind of the pathway that you've described. And so I guess I just wonder about those kinds of things that I think there's been a shift to increase the competency and the expectations of those receiving a license in our state, which I think comes with added protection for clients and the that integrity of the discipline. I also think we have to acknowledge that we have to do things different. Right now, I don't know how we're going to meet the needs of people. And so that may mean that, we have those groups that are very robust and present in addiction, on that addiction side. And as we integrate more and more, what can we learn from that? And being able to provide some of those services that are so helpful and supportive, and that those actual therapeutic clinical interventions could still be provided by those that have the training, the expertise to do that, and that it's not one or the other, it could be both. That we could have kind of that plethora of services that allows people at different levels to be able to provide those services.
Yeah, Ms.
I don't know if
Ford,
that's making sense.
yeah, no, I think I'm on the same track with you, and I support it. Oddly enough, we're asking a lot of our behavioral health clinicians to actually go and get an addiction certification. So we have a partnership with KU to bring some of their pre-doctoral interns to Community Health Center to receive specialized training from our addictions treatment staff, because they've identified that their curriculum doesn't have enough addictions training within it. And so we're asking our clinical social workers to go back and get their LMAC because they can test for it directly with a master's degree. And I met with our chief strategy officer, our president here, Jason Wesco, and one of the things he asked, he said, Eric, they're going to want to know about a fiscal note. That's a big question that comes up when we have these conversations. And honestly, and this may sound wild, and I think it speaks a little bit, hopefully, about my heart, is I'll take what I can get. I'll take a provider not paid so I can get them to become an LAC, and then we can bill, right? What we've identified, I'll find a way to subsidize it within our programs. What we've identified is there is just such a tremendous need. And even if it starts as a pilot, maybe with Shane's team, or figuring out a way that we can integrate folks into treatment and with the appropriate academic rigor to support it, I think is incredibly important. And I think that baseline bachelor's is incredibly important as well. And one note you made about case management, I'll stop rambling. As a federally qualified healthcare center in Kansas, we don't get access to some of that behavioral health and addiction treatment case management codes. Mm-hmm. And so as the largest medication assisted treatment provider here in Southeast Kansas in our service area, it's incredibly challenging for us because we can't take that approach. And so a lot of times what we're doing is we're developing community health workers, we're developing our peer support mentors who are interested, and really empowering them to help advance their degrees and their training and scope of practice.
I just think that's such a key component as we talk about this, that, you know, again, that complexity in the nature of individuals' care and treatment. It's not one provider, and then you start getting all of these other, you know, individuals together, and to make sure that we're all talking and everybody's kind of coordinated, like there's such a need for that coordination of care. So I also wonder about that. I know that's not what you're requesting, but I guess
Sure.
I just wonder about those things as being increasing the effectiveness of the treatment that you're, you know, that we're trying to provide. And I mean, my hat is I work for the School of Social Welfare for KU, and I mean, we are definitely trying to infuse more co-occurring, more of the substance use awareness. We've developed courses at the bachelor's and master's level. I mean, I'm always the squeaky wheel in our curriculum meetings about this, and I'm not alone. I think we do have, you know, even our accreditation standards are starting to include this. So I mean, it's coming. It's there, it's part of it. But you know, these are big ships and they take a while to move.
Sure.
So could Eric, just to kind of look at this, ask another additional question. What do you see as the big change from the way it is now? I mean, what you're requesting, the modification, what do you see as the big difference from what's currently in place? What would this change, or how would that benefit you?
Yeah, so I think I think the change, of course, is identifying another level of licensure. And I think what that would do to benefit the patients in our communities is to allow people who are interested in the addiction treatment world, providing that counseling level of support, to enter the field and hopefully keep them there. I followed up with someone who graduated from Emporia State, bachelor's degree in psychology, applied for an addiction treatment position in Iola, Kansas, right? Which it's so incredibly hard to find folks in Pittsburgh. And it's like looking for a unicorn with like vertical stripes in Iola. So we couldn't onboard her. So I asked her, I said, hey, what are you doing now? And she said, oh, I'm doing case management. Well, that's great. Still in the mental health field. Do you like it? And she says, it's okay. And so it's like, well, how long are they going to stay at? It's okay. Or are they going to move to something completely different outside the field? And so I think for me, it's workforce development. It's training. It's getting them involved. So we have case conferencing at CHC. Our counselors meet every other week just as counselors. And then every other week on the opposite weeks, we have everybody within our addiction treatment program. So it may be our medication assisted treatment providers, our bachelor's prepared social work who really focuses on care coordination, our peer support mentor, our jail navigator. All of those folks get together to staff cases, our nursing staff, to really, as you were saying earlier, have that continuum of care. And so getting entry-level folks into those meetings to hear the thought process and why people are thinking along the lines, why they're diagnosing as such, I think is incredibly important, and will only contribute to them developing their own skill set and maybe pursuing higher degree.
I think from a workforce development standpoint, I think I could really see a push for a limited time licensure piece like you're kind of describing with the provisional. I think we'd have to be really careful to say, well, we're gonna provide this piece and allow it to go any longer than a certain period of time. Because what it would really do is allow you to hire people and then allow them access to some of the benefits that some programs out there are already providing, right? Like tuition reimbursement. Whereas if you can't hire them at all, you can't provide the tuition reimbursement. But if you can bring them on as a full-time employee and have them have access to the benefits that some provide, then you have a better shot of keeping them in. And so how do you bring some on? It's kind of like an extra training program, it sounds like to me.
Yeah, absolutely. And another thing to note, HRSA and NHSC, depending on level of licensure that's permitted through the BSRB, they will start paying back tuition for addictions counselors now, for substance use disorder folks who are working with the substance use population. And so these folks are leaving college with loans. We're saying, hey, you got to go back before you can even qualify to work here. And HRSA, I mean, they'll pay for a bachelor's prepared addictions counselor. They'll reimburse through NHSC Loan Corps. They'll reimburse their tuition. So exactly what you said, we have all of these benefits, but you can't get to them until you're an employee and you're in the field.
Well, Eric, I really appreciate all the thought that you put into this. And I also appreciate I guess, a proposal that has at its base level, the bachelor's level. I think there's going to be some conversation at some point about counselor in training again, that would be potentially even less than that as an entry, but I think this is a bit more palatable. And I do think the time limitation is also a positive thing. I guess I have a couple questions. One is, this proposal has very specific bachelor's degree in psychology or social work. Normally, especially in our field, where we tend to use the term related fields. And I'm just curious your opinion about using some of the language like that instead of limiting it to just these two.
Well, specifically for bachelor's prepared clinicians, for me, I want to make sure that they have some component of therapeutic communication within their training. Addictions is a unique field. It requires a specialized person. And for me, I think it made a whole lot of sense from that perspective. That said, we have a phenomenal licensed clinical addictions counselor. Her master's degrees in criminology. And so I think, or criminal justice. So this is just how I conceptualized it based on the current statutes and the pathways to get a license or to test for an LAC from a bachelor's prepared clinician or a licensed bachelor's social work.
Okay, that's helpful. Your bullet point here talks about additional coursework to be eligible. What are you envisioning with that?
Well, so specifically, Pittsburgh State University doesn't offer an addiction services coordination or co-occurring disorders course. Their introduction to addiction is offered one class per year. Their family addiction piece is offered one class every other semester, and their introduction to addictions is one class every other summer, or addiction pharmacology. So for me, we are going to have folks that are graduating with a bachelor's degree and they missed one of these courses.
Mm-hmm.
And so to be able to bring them in under the understanding that one, you're going to be receiving clinical supervision, because maybe they didn't get an addiction practicum as a bachelor's in social work. They just got or a bachelor's in psychology. They just got a different practicum. So you're going to be receiving clinical supervision, and to be eligible to test for an LA for your examination, for your certification, you have to get these courses done. And so it gives us a 2-year period, gives them an opportunity to have time to continue their educational track and then test for certification.
Okay, that's a very helpful distinction. So I'm glad we kept talking. So in your mind, you're not asking to change what's currently there for the permanent license. You're asking just to allow for a temporary or provisional while they work on it.
Correct. For people who have already graduated their academic institution with their bachelor's degree.
And then my other question was scope of practice.
Mm-hmm.
How do you see the scope of practice being different for this credential than, let's say, the usual?
Yeah, so I don't think we'll see a ton of scope of practice changes. The thing that we may notice more is documentation of supervision. With some of our other specialties, social work, for instance, both the supervisor and the person being supervised has to keep a log of the things that they're doing, tracking hours, submitting them through whichever agencies to ensure that they're staying timely, come up with a plan for what that may look like to get approval. I think that's really where it can come into place, instead of necessarily endorsing diagnoses, right? So we may have an LCAC endorse the diagnosis of an LAC, more so in a mentorship, training, educational role that we see with other areas of clinical supervision. I think that would be the big difference.
Yeah, so diagnosing, of course, is not a scope of practice for an LAC.
Mm-hmm.
So that's always kind of been a sticky wicket.
Yep.
So you're not really suggesting they're going to render that and be signed up. I mean,
no. So
Okay.
the way that we call it, sorry, I'm a psychiatric nurse practitioner. I call it diagnosing, diagnostic impressions.
Yeah.
So what our LCACs will review are the diagnostic impressions that they're seeing from the LAC. And so if there's ever any documentation that's required in regards to court or other things like that, that's typically
Okay.
taken care of by our LCAC. So I would say that scope of practice would remain similar.
Do you think the two, I mean, unfortunately or whatever, I mean, being kind of in my seat and on the board, you put something like 2 years and immediately there's 15 exceptions for some inane reason to that. So in general, for things that are going into law, it's a little bit better to make things a little broader. So you catch a little wider net without, giving away the farm. Thoughts on that?
I think that's tough because what I don't want is I don't want folks that live under this provisional license.
Oh, absolutely. It has to have an end date.
Yeah, and so whether or not there's exemptionary status or if they can resubmit for a extension of a year or what have you, as a clinician and administrator here, I want my staff to be as educated as it can. And I absolutely want to be in full compliance with the BSRB. And so I 2 years is 2 years. That's a lot of time to take potentially 2 classes.
Okay. And then what about any continuing ed or other training while they're in that status? Do you just see them focusing on this?
Yeah, I would say focus on this. There's some exemptionary stuff with the American Nurses Credentialing Association, where if you're pursuing education within like the related field of a nurse practitioner, that counts for your CME. And so what I'd like to see is as long as they're continuing on with their supervision and their supervisory plan, which would include the academic parts of this, that they get credit for that.
Very good. Members have any other questions for Eric?
I appreciate all the work and thought you put behind this. There's got to be something we move towards as we talk about workforce and getting quality people that could do great work in Kansas and not trip over some of the barriers that seem like we could resolve a little bit. So I appreciate the thought process and ideas behind it.
Thank you all very much. I know I took more time than I was supposed to.
You're fine. Thank you. Appreciate it. Well, that was good. I enjoyed hearing a definitive proposal.
Eric, I've spoken to a couple times before. They're doing great things down there, and he's a very sharp person who, I mean, knows a lot of things. And I think just bringing all those areas together and putting some thought in this direction is helpful.
Yep, definitely. I heard from James Childers, who works for Crawford County Mental Health Center, who's also he's the chair of CAP. And so he has been kind of saying the same thing, so that would basically, I don't know if they've talked or what. I almost was going to ask Eric that since they're in the same neck of the woods. But he also had a proposal to add another credential that would be targeted toward individuals that had completed at least 60 hours of a bachelor's program, currently enrolled in college and actively working toward meeting the requirements for the LAC. They'd have to submit an educational plan, et cetera, et cetera. So basically his proposal aligned with Eric, but he added the second one.
So when he said 60 hours, was he saying it had to be, because that's hitting that mark of an associate's degree, 60 hours.
Right.
So they'd have to be pursuing the bachelor's was the idea?
Yes, and
Okay.
their intention is to be an LAC.
Right.
Kind of more of the straight, I'm working on my dictions versus I came about it through the back door kind of thing.
Gotcha.
With
That
other
makes
disciplines,
sense.
or I changed my mind, I want to do this, or
Right.
I came from another state, whatever. So
I haven't heard any like overt like proposals on this, but what Mr. Tomlinson suggested, absolutely the practicum providers that I utilize in my position, they encounter the same stuff. They have lots of applicants, but they're not quite there, and there's no way to get them on board unless they happen to fit peer support and they can get them in that door.
Yep.
And I know I have a number of students that come through that don't fit the peer support, and there's no place for them to really go to get started in it,
It's
which does
definitely-
keep them.
It's a gap. I would agree with that.
Yeah, I'd say the kicker on peer support is lived experience and all of that, which that gets difficult. Yes, when you have someone who doesn't meet that, getting them in. Otherwise, it is a nice pathway to have peer support. I
Yes.
like that, but I wish we could, figure out the pathway for those who don't have the lived experience.
So one of the questions that has come up, so if you review the old counselor assistant stuff, or even I think apps credential counselors, you only had to be 18. And of course, everything with every license now is 21. Jason is signing off. Thanks for coming with us, Jason. So I'm just curious I don't know, I'm not too jazzed about lowering the age requirement for a regular license, I'll call it, but maybe this would be an opportunity to lower it for this. I think 21 would probably be a bit onerous, and we would perhaps regret that.
It's a good question. I haven't really thought about, the age component hasn't come up in the situations I've seen as far as bringing staff in because they've achieved their education and have licensure in another state, et cetera, for that example. But that's a good question. I don't know. My initial reaction is, 18, you're learning and doing some things. So I guess it's progression forward towards something else. And if you're doing a 2-year program, then you're 20 by then. And I don't want to be ageist in that process. I just haven't considered that before.
Yeah, I hadn't either. Like I said, all the other licenses with the BSRB it's 21. So I'm sure we just said, hey, we need to once again align with everybody else, but perhaps, and maybe it's just 19, maybe it's 20. I don't know, but it feels like maybe if we pursue this will be a good opportunity to lower that just a tad.
Do peer mentors have to be a certain, I can't remember, adult maybe it's just 18. I'd have to look back at what KDADS has set up.
I don't remember. So. Well, I think, just kind of trying to look ahead a little bit. We've got 3.5 months until session. If this group is interested in trying to get in front of this and offering something specific for statutory change, then we may need to consider either, I could request a subcommittee from the BSRB as a whole to look at this closer, or maybe this group just needs to meet more frequently between now and session to hammer some of the details of this out. I'm a little concerned just based on what's happened in the past couple sessions that someone will get in a little room and decide on something and it'll get floated and everybody will think it's the best thing since sliced bread because it's going to get more people in the work, and it may not be what we would have wanted it to be. So it is an opportunity to get in front of something as opposed to in reaction mode, for sure.
Yeah, but I think that's a great idea to maybe meet as this group. I'd be willing to do that. I think it is important, and it's nice to have like something that's, like you said, concrete and that we could work with and maybe recommend this is the recommendation based on this committee, and then be able to have something for them when they come back. I think that I would be in favor of that, I guess.
And I would be willing to meet more regularly to work on this. Like I said, we've been having lots of conversations here locally about it, and have been engaged in other groups because they're looking at multiple professions, nursing as well, right? It's a huge thing, not just addiction counselors, but I'd be willing to meet more regularly in order to hammer something out.
Yeah, I agree. It's a big thing. A lot of people are talking about it, but having an opportunity to do something with it. And as we talk about all these different thoughts and ideas of people who might be great at providing something for us, but aren't able to at this point. And just to know, I looked up the peer mentor eligibility. It is 18 years of age or older. And of course, a minimum of 1 year in stable recovery. So those would be those foundational pieces versus like all the training certification components. So there's maybe space if you talk about a similar pathway, 18 years or older does exist in some way.
Very good.
Yeah, and I'm willing as well. I think, Deb, you're right on, if we can get ahead of it versus reactionary, that's usually to our benefit trying to figure it out. That's whether it's this kind of stuff or other stuff. Absolutely. Yeah.
Very good. Well, I will, one of the things that hit me, because I was reviewing the old SRS stuff before the meeting started, and it hit me that it is imperfect, and I don't necessarily want SRS KDAD's trying to take this on, but all of that is still in current law, to be honest. And the law says that KDADs may establish minimum criteria for those working in licensed and certified alcohol and drug treatment facilities. That is current law. And those are current regs. Nobody deleted them. They're just ignored because of counselor licensure. So like I said, we certainly don't want to expect KDADs to take any of that back on. I think at some point we need to loop them into some of this conversation as well, given that they have that statutory authority.
Scott Bruner has been a part of the conversations that I've been a part of with KDADs. So I know he has some awareness too, but I would agree in further looping them in.
Well, and yeah, I would want to bring in Commissioner Bruner. He's actually over licensing, and he really doesn't have any authority over that, to be honest.
Yeah.
So anyway, good. Well, we'll just plan on convening some additional meetings between now and then. And David, I'm sure, can assist us with some doodle polls. And I look forward to those conversations. I also had to realize that one of my favorite things to say in the board meetings is that it is our responsibility and our duty to look at how to bring in additional folks. Yes, we're here to protect the public, but part of that is to ensure that there's adequate workforce to actually serve the public. So I got to challenge my own self about saying that for the last 6 years, as I have had kind of a visceral reaction to even this whole conversation. So, but I do like this. I like this on multiple levels. So the only other thing I want to throw out for this group about this, and we can talk about it more later. So as I look at who's on this call, I look at who brought this forward, James Childers, and who, you know, and where he works. Just a reminder, the field is full of, the alcohol and drug field providers is full of small mom and poppy shops. 1, 2, 3, 4 people working in them. And anytime you lower that bar, you run the risk, frankly, of it showing up in a way that we didn't intend, as we all consider the large agencies, institutions, structures, supervision, accountability structures that most of us work in. So that's where I think KDADS is very important as well. Yeah, especially with the scope of practice that we're talking about.
And can we wrap into this conversation those who do have education and experience that really warrants, you know, that look at how they could practice as they move over to Kansas versus, you know, just or in this other part of the conversation, those who might be younger without the education and experience, and the pathway for them to support our agency and our providers and make a space for them. How do we get those people who've shown, you know, they're educated and experienced to have a better pathway supporting them into Kansas?
Yeah, David and Leslie would have to help me kind of explain. I think that's a little bit of a different, you know, fruit, if you will. I mean, if this is apples, that's maybe a different shade of apple, just because of then you're potentially saying that other folks don't have to meet the same requirements that Kansas folks do. So I'm not saying that.
Or maybe even opening up a discussion around case examples. So maybe that would even bring further understanding to providers and agencies, you know, like myself or others who want to just discuss some case examples and like, you know, did we miss an opportunity with this case example, that kind of thing. Name redacted, et cetera. If we talk about circumstances and things, that might be helpful as a process.
No, I agree. We just have to be very mindful of the exact language and statute that we want to change, because at the end of the day, that's all BSRB has. Like even during COVID, we couldn't do anything. I mean, people were mad, you know, they were on us. Hey, you need to do XYZ other places. We can't. We have no authority unless the governor says you may, have this blanket change. You may waive things, BSRB, unless something like that occurs. We always have to go back to exactly what is written. And that's the only authority we have. We don't have judgment, if you will. Yes, there's judgment that comes into play about felonies and things like that. But when it comes to requirements, that's what we have to rely on. So I'm just
There
throwing
could be-
that out as I wish it was easier, but it is what it is.
There's a pathway for change, though, if we thought it was really important to bring
Well,
it up with.
absolutely, yeah, I'm just saying
it's just
it
not
has
as
to be
easy as a
statutory and
BSRB.
regulatory.
Yeah, right.
Yeah.
So yeah, if
that's
we could
all
just
I'm
have
saying.
maybe that's a separate conversation, but if we could look at that a little bit more closely and just understand it more, I think that would be a valuable process.
I do think, and again, David can correct me if I'm wrong, he's attorney by trade. It feels like this would be an opportunity for those people as well.
I'm sorry, Deb, could you clarify that?
Well, I mean, if all they're lacking is a course, right, then that's okay. Here's your temporary, go to work, go get your, I mean, everything's online, hopefully. Go get your course. The agency
I think
can
that's
pay for
true.
it.
I think we'll invest in that and figure out what kind of contracting with that individual to keep them on at our agency as we support them through the process. But I mean, what will happen is that we'll pay them as if they're a master's level clinician or what have you. They'll come in as lower. There'll be a gap there in what they can provide and bill for, which we can do. I mean, that's at least change in the right direction, considering
Where
if
we
this
are.
other avenue can't be one that happens soon or anything like that. So yeah, I agree. Any good change is good change. So
let's, as we walk through that, Shane, and then if you have some case examples, let's use that as a test. I mean, I'm hearing what you're saying. And if there's something else we can do, then we'll look at it for reciprocity purposes. Because I think we need a change or two, but I mean, the addiction field is already so loosey-goosey because everybody comes at it different ways. We don't have a national crediting body, blah, blah, blah. Well, we do, but you know what I'm saying, in our colleges and universities that we've tried to create some, flexibility around some of that, but we got work to do. So, wow, that took an hour, but I think it was worth it. I think the next item on the agenda is to review the minutes from June 24th, if you've had a chance to do that. And I would entertain a motion to approve.
I move to approve the minutes from June 24th as submitted.
Second.
All in favor, say aye.
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 Any opposed? All right, Executive Director's Report.
Okay, thank you, Deb. And before I begin, I just want to make sure you're aware Charity Kosin did go ahead and log on to the Zoom, so she is
Fantastic.
present at the meeting today as well.
Great.
And I'll try to keep my notes.
Sorry, I was late.
You're fine.
I'll try to keep my notes short in terms of the Executive Director's Report today. Just to let you know, we are under still some of the governor's direction for limiting in-person meetings. So we'll continue to hold most of the advisory committee meetings remotely until those restrictions are loosened or taken away. One item that has been a major undertaking for the agency recently, all agencies are required to submit a budget by September 15th of every year. And then it goes through the process of being reviewed by the governor's office through the division of the budget. And then the governor makes recommendations on agency funding in the spring, and then the legislature reviews those and makes additional changes when the session goes on. So we did submit a budget for the BSRB with revisions to the current fiscal year, which is fiscal year 23, and then also a budget for the next 2 fiscal years, fiscal year 24 and fiscal year 25. There are some slight increases for those 2 years that we put into the budget request. A lot of those have to do with anticipated increase in costs that we're going to see based on who we contract with. And then also some of the items that we currently spend on right now. With the pandemic, we expect that things will continue to get closer to normal. And so we'll be able to go out and talk to more schools in person rather than doing those remotely. And so there's some travel related expenditures that are going to be going back to normal, we hope. So also BSRB was required to submit a 3-year IT plan. All agencies were asked to go ahead and do this. And so as some of the long-range goals that we're working on under this 3-year plan, we are continuing to look at phasing out some of the technology here in the office and replacing some of that technology, requiring cybersecurity training for all employees. We are also looking at trying to move forward with having some of the initial license applications be online as opposed to by paper. And then also trying to look to see how we can replace some of our paper records with electronic storage of the records. So optimistic about some of these goals, but they may take a little bit of time to put into place. Wanted to provide some updates to you all from the last board meeting, which took place on Monday, September 12th, this last week. So the board heard a presentation by a company called CE Broker. That is a company that had spoken to the board a few years back. They provide an alternate method for handling and auditing of continuing education when people are pulled for audit when they renew. So the board received some information and will be weighing whether to continue conversations with that agency or that entity. Also, the board heard information from a representative of Heart of America American Professional Network on impaired provider programs. Some states have programs set up for individuals who either go ahead and enter the program voluntarily because they have an issue with substance abuse or also with mental health concerns, or sometimes states use a program like this as one of the options under its disciplinary procedures. And so they received some information from the individual who is associated with the provider network here in Kansas, and we'll be having further conversations on that topic. Additionally, the BSRB had a discussion about practitioner responsibilities for clients when those clients are in crisis as it relates to the national rollout of the 988 National Suicide Prevention Hotline. The board also made some additional changes to the investigation policy, followed by the complaint review committee for the board when evaluating complaints against practitioners. And also the board, there was an announcement made, the annual meeting for the board in terms of an offsite planning meeting is scheduled to be an in-person meeting in Olathe on Monday, October 24th, 2022. One legislative update I wanted to make the advisory committee aware of. On September 27th, the Robert G. Bob Bethel Joint Committee on Home and Community-Based Services and Can Care Oversight will be having a legislative committee meeting here in Topeka, Kansas. On behalf of the BSRB, I've been asked to attend that meeting and provide testimony. There are some updates from a past committee that dealt with mental health modernization and reform. And so they had asked anyone who was with an agency connected to those recommendations to provide additional information and to speak to any recent actions by those groups that might connect to some of the recommendations from those committees. And then also in terms of one other update, the Kansas Fights Addiction Grant Review Board I've spoken about a few times in past meetings. That grant review board has started to meet. The first meeting was on July 14th. And the next meeting is going to be this last week of September. It will be on Wednesday, September 28th, and that will be from 9 a.m. until 1 p.m. at the KBI Forensic Science Center Auditorium in Washburn University. So on behalf of the BSRB, I'm currently the appointee to that advisory addiction grant review board. And so I will be attending that meeting. Most of the meeting will probably be open to the public on general matters, but they may go into sort of a closed executive session when they get closer to talking about specific applications for grants from entities that are requesting funding from the board. So with that, I'll go ahead and end my report and stand for any questions.
I missed the date of that, Kansas Fights Addiction Grant Review.
Sure, and that just came out earlier this week. That is going to be meeting on Wednesday, September 28th, from 9 a.m. until 1 p.m. And it's going to be an in-person meeting at the KBI Forensic Science Center Auditorium at Washburn University.
And do you know if they're going to offer like a YouTube stream?
To my knowledge, I think it will just be an in-person meeting. There've been some discussion about that, but I think the will of the committee, the first meeting was to try to do as many of them as possible in person. So it may depend upon how many attendees they have at this meeting.
Got it. Okay. Sounds good. Do you want to just go ahead and do that on new business? Or do you want me to, since you just talked about it?
Sure. So the item as far as the care of clients in crisis.
No, B. the appointee that the board talked about?
Sure. Yes. So the Kansas Fights Addiction Grant Review Board was established in statute. And when that was established, the bill that passed that created the Grant Review Board indicated that there are certain entities that would name an individual to serve on the Kansas Fights Addiction Grant Review Board. And the BSRB was named as one of the agencies that was going to be naming someone to sit on that board. And in the statute that established that, it indicated that at least one member, each member shall serve at the pleasure of the appointing authority. Such board shall be composed of 11 members who have expertise in the prevention, reduction, treatment, or mitigation of the effects of substance abuse and addiction. And so at the recent board meeting, the board did discuss, I'm happy to serve as a representative from the board, but given that language and statute that talked about the members of the board should have experience, expertise in the prevention, reduction, treatment, or mitigation of the effects of substance abuse and addiction. That's really not my background. And so I asked the board if they could take a look at finding another individual to serve for the future. Now, it does not have to be a member of the board. And so the board discussed who could be an individual to serve on that grant review board. And so they asked me to reach out to the different members of the advisory committee to find if there was individuals who had that background that could meet that qualification and that would have interest in serving on that grant review board. Now, to my knowledge, I believe at the first meeting, there was discussion about potentially the grant review board meeting every month. But based on scheduling so far, I think it's more likely they might have meetings every other month. Right now, the meetings are in Topeka. The first meeting was at Washburn University as well. So that seems to be the location where I think they want to have most of their meetings. The first meeting was about 3 hours long, and this one is scheduled for about 3 or 4 hours based on how long that meeting lasts. So those are some of the parameters right now. But I wanted to make you all aware of it. I will be sending out more of a formal message to advisory committee members and then collecting interest on that. And then in the future, the board will be able to review those individuals who had expressed interest and determine who should be the board's appointee going forward. So I wanted to kind of summarize that and bring it to your attention so you would be aware of that.
Thank you. So, I mean, there was quite a bit of discussion about the members of this subcommittee in the board meeting just because of the expertise that we have. So I guess be thinking about whether you have an interest in applying to be the representative from the BSRB for that, whether you have the time and that kind of thing. And then as part of that too, we're going to ask the person to make a report out at, our regular board meetings, or at least something in writing, if not a lot has happened, so that we can keep kind of on tap with that. So thank you, David. Appreciate that. On to old business, continued discussion on possible continuing ed requirements in diversity, equity, and inclusion. So we tabled that last time, Christina, because you weren't there.
Okay. So are we opening that discussion up?
Yeah, I think so. And I think, if we're planning on, proposing some pretty major additions to the law around addiction counseling, I think that would be certainly one that we could continue. I'm still, just to be honest, pretty pessimistic, I think, about whether it would get approval or not with the legislature, but.
So, Deb, you definitely have a lot more experience in this and knowing what, as far as any recommendations made, is there room for like the information to support that, the research behind it? There's actually, I was just able to find a couple of different things just that recently came out this year in April. One came out from USC just talking about racial disparities and accessing treatment for substance use, and highlights the work to be done, and just talking about one of the critical issues is still lack of cultural competency in the healthcare workforce, and it's an issue and it's documented. And so I don't know if those things would be like how that's conveyed. I think like we've talked before, to me, it's just important if we make the recommendation, like you said, we can't control what the legislature is going to do. I think if the recommendation is made and it's heard and it keeps coming up, that may do something towards the legislature being more open to it at a certain point. I guess that would be my hope. All we can do is make the recommendation. I know we can't control
Yeah.
them. They may not do it or allow for that. I do think it's worthwhile, and it's still something that we're seeing as important, and it affects outcomes, so I guess that's where I'd be, and would love to hear if there's ways to present that in a way where they get to hear the other information, or I don't know how that works exactly.
Yeah, and I'm not sure, I mean, not sure we're quite to that point. I mean, I think we need to articulate what it is for those that are in support of this, what does that language look like, right? So is it fairly, I'll call it generic, like we have kind of now with ethics, or would it be a little bit more specific? I mean, so it's those kind of things. How many hours? Is it every 2 years? Like, what is it that we would even put forward, assuming that there's consensus in this committee to even try? So I'll wait and whether there's talk.
I think we'd have to keep it pretty broad like we do with the ethics, if for no other reason, practitioners being able to find something that fits the category. Not that it's not out there, because I know it is. And I agree with Christina, it's absolutely necessary and needed, but I'm kind of on with you, Deb. I don't know.
I agree with that.
Yeah.
Are you, Charity?
As a assistant counselor in rural Kansas, especially when I go to do my license renewal, it is difficult for me to find some continuing education, like diagnosing and different things like that. And there's just not a lot offered in the state of Kansas for education. So I think it is necessary 100%, but I think it would have to be kind of broad so that we can find continuing education hours that would align with that topic.
I will just interject as an aside that the CE broker that David talked about, that we had a presentation in the board meeting on that particular company. Part of their kind of claim to fame is to serve as a broker for licensees to find and access training. And they have everything from free to, of course, things that probably cost a pretty penny. They don't offer it themselves. Again, they're just brokering that for those folks that do that. So if the board chooses to pursue that particular, I think some of this at least might be a bit easier, because that was one of my concerns too when we brought it up, was like when the BSRB requires things, I think a good example in my mind is the clinical supervision training by the couple of disciplines that's now required to be a clinical supervisor for those seeking their post, their graduate clinical practicums. That is, that can be hard to find. And it's like, we've got to be mindful of things. If we're going to require them, they're actually available to take. So I think if we pursue that, that'll probably be a little bit easier.
I would agree. And I think just kind of as a reminder, going back to what we had discussed, I think the number of hours, I mean, I think that's something we could look at, and that could be very, like, whether that's 1 hour, 2 hour, 3 hour. Also, that we had talked about maybe looking at the requirements for diagnosis, that was kind of an arbitrary number that got set at 6.
Mm-hmm.
Nobody could really remember why that was set at 6. And so what, could there be a give and take there to say, okay, you don't need as many of the diagnosis, so that there's not all these hours, that they still have some discretion over that? Or is it making it at least 1 hour? I think it also sends a message when we say,
Mm-hmm.
you have to have this. If it's an hour, it's something, it's more than maybe some get. And so I do feel, I guess, and as you meant, I mean, I do feel strongly about this, and I think it's something that just like with ethics, I guess around the idea of its availability, it also lends to if it's required, more people are going to offer it because they know it's something
Yeah,
that people will
that's true.
take.
That's a very good point.
So, I mean, I think that, and with the availability of online and all these different vehicles to access CEUs, I guess I think that if you want to find that because it's required, it probably will be offered, and people will offer it because it's required. So I don't know if there would be ideas on just the hours. I mean, do people have a strong sense of what would be fair or appropriate, or if that's even, I mean, again, like you said, is there even consensus with this is something we need to pursue?
Well, I appreciate you bringing up the in lieu of the 6 hours for diagnosis and treatment. I think, I mean, 6 full hours on SUD diagnosing is a bit, much, frankly. So I also wonder if that'd be a tiny bit more palatable with the legislature, that we're not adding, we're just kind of replacing. So I'll open it up for thoughts on that.
Expanding, not replacing, Deb. So
I agree that,
yeah.
oh, sorry, Michael.
Go ahead. No, go ahead, Shane.
Just a brief comment that I think that when I do the diagnosis component for my LCAC every couple of years, I end up taking probably the same 3 ones, like they've been updated, but it's like through Relias, and we have this online, and that's the easiest place for me to access it, and our agency's paying for it, so why go purchase something else? So I end up taking like kind of the same regurgitated courses that have been updated, and it's a long period of time. As Deb said, 6 hours is a lot, but finding better, like I don't even think the 6 hours is necessarily quality, because you just find something to plug into that space, whatever it is, and you're so thankful you found something that said diagnosis in the title and or the description, and you could tie it in there and you get it done and you move on. So I don't know that it's really even that effective to say 6 hours, because I'm not necessarily strengthening and learning new things, or it's not that valuable to me, I suppose. I'm just getting it done.
I would agree. I know a lot of the folks who hold the dual licensure, will find something that has both, right? And just say, but that's not the majority of the field, probably. In fact, I know it isn't.
And I'm going to go ahead and add this to the conversation too. So there was a comment about if 3 of the hours or however many hours could be exchanged from the diagnosis and treatment. The bachelor level does not have the authority to diagnose and treat. And so for the continuing education requirements, they have 3 hours of ethics, but they don't have that similar requirements. There would need to be something a little bit different for that licensure level, if that's the
Thanks for
proposal.
the reminder on that.
Okay.
So I don't know, like even to me, I think if on the I would love for it to be 3 hours. I also recognize, again, what's feasible, compromise. Like even if it was to say 1 hour of your CEUs every 2 years has and again, the wording here I know would be important to make it broad enough to allow for, but to make it specific enough to really get at what we're trying to get at. So whether that's in diversity, equity, inclusion, and then I don't know again why if we go with the diagnosis and treatment being 5 hours, that's kind of a random number. I mean, as far as even if you do take it in person, like how the timing of that, but I mean, there's nothing that says you can't get more and count, just 5 hours has to be. You can always get more if that's the way it's presented. But I like the idea of expanding it. As Michael said, I love that reframe. And, I know it's been brought up too before, and I've thought about this, that, other disciplines maybe aren't doing this or haven't required it. I think it's great if we can be on the forefront of that and to say that, again, this is important. There's a disproportionate effect on those that we treat in this field, especially.
Just a reminder, psychology tried. And it was summarily deleted. I mean, the rest of what they wanted was approved, right, David?
That's right. The other 2 really had to do more with, there was an addiction counseling item in the bill.
Oh, that's true.
one
Yeah.
as far as the social work item. So the only one that LPs had exclusively was the DEI training.
So what was I thinking? What do you think about bachelor's level? Just adding? I'm just kind of the opinion that we should, that's my idea. 3 hours, just say it. I mean, I think if we're gonna try to take the hill, but I do think, dropping the diagnosis and treatment to 3 is more palatable.
I like that. I mean, I think it does and I mean, I've taught some of the diagnosis and treatment. I do those presentations, and sometimes it's a labor to try and find. Oftentimes it's weaving in other aspects of cultural sensitivity, all these things anyway. And that could be one way that, I mean, I guess I just think of when providers are looking at that, they could do 3 hours of diagnosis, 3 hours of DEI, that it could all be interrelated. So, and there's so many different topics that could be related to that's a big component. So, I guess I just wonder too with the legislature, I mean, like, I think if it keeps coming up, if we keep presenting it at a certain point, there may be some impact, and that may be advocacy on that side too that needs to happen, that that awareness and getting to I'm a
Well, I'm
voter.
just going to say this one sentence. Everything around that issue got politicized last year. So
yeah,
that's it. Anyway, agree with you completely. Anybody thinking we're barking up the wrong tree here?
I think it's important. I think, do we keep presenting that as part of, because we know it's important from the data and the information we know about treating individuals with substance abuse issues? Or do we prioritize the components of expanding the field and the previous conversation? Which one do we stick our energy at this point, as far as what's most likely to be able to move forward, and how much is too much to try to tackle at one time? Or I don't know. And legislatively, if you send them all kinds of stuff, do they just refuse everything? Or how does that tend to kind of play out? I think maybe we need to prioritize which ones are most likely and most important. I hate that word, today, that we might be able to tackle. Because no, I absolutely agree. And the courses that I teach have that embedded throughout. And they probably get sick of me saying things around it, honestly. So that's just kind of my 2 cents. And with the clinical level, the master's level where they can diagnose, it might be a simple change of diagnostic and or the DEI stuff, which then broadens it for them and gives more options. And that may be more palatable at that level, but I don't know what to do with the bachelor's level that doesn't require the addition, without highlighting that we're adding this piece that may get the politicized reaction kind of thing.
Does it have to be the same? I guess that would be, I mean, just as you were saying that, I'm wondering, could we, we could say the recommendation would be 3 hours of diagnosis, 3 hours of DEI at the LMAC or at the master's level, bachelor's level, at least, there again, we could say 1 or 2 hours. If that would be, I'm just asking, does it have to be the same? Or could we make that different? Or make that recommendation? Or are there reasons not to do that?
I can't think of any compelling reason not to do it. Just from, again, the seats that I've sat in, consistency tends to be kind of something we try to do. So, because otherwise people get confused, and I hate creating rules that are intentionally, can be not intentionally, but you know what I mean, have that as a byproduct because it was intentionally different without a compelling reason to be different.
Makes sense. Yeah.
Are there movement from the other fields to attempt this again or not? I mean, that might be one of the other avenues, is, if the behavioral health world in general is all saying the same thing.
It'd be nice. Hasn't come up in a board meeting, but David attends the other advisory committee meetings, so I'm not sure.
Yeah, so the social work profession, they did a survey to social workers back in December of 21 and asked them questions primarily on supervision, but there was one question that asked if they would be supportive of 3 hours of continuing education in DEI. And I want to say about 60 to 65% said yes. So the majority of individuals who answered the survey did say that they were supportive of that for the social work profession. So that advisory committee had forwarded a recommendation to the board to continue the conversation and continue the discussion on that. They didn't have a real formalized recommendation to submit to the board, but they did advance it from their advisory committee for the board to continue to have discussion on the topic. Some of the advisory committees have talked in favor broadly of people taking continuing education in this area. But I think the licensed psychology advisory committee, they didn't advance something specific this year. They just had conversations along these topics.
Do you think, David, that that's helpful? Like, again, I don't know what information gets presented to the legislature on this, but having that kind of grasp, from the field, these are individuals that are going to be required to take this. They are in support of it. Is that helpful to have that? Would that be something we might want to look at? Like, could we do a similar survey of those that have their addictions licensure? Would that be helpful or not? I don't know.
It could be. We don't have a great way of doing surveys for a large number of individuals to respond to. For the social workers, there's thousands of licensees. I want to say around 8,000 currently of all of the social workers. So over 1,000 responded to the survey. And so we went ahead and spent a little bit of money to go ahead and have that data collected and organized for us. But it wasn't a lot. So I think there could be some ways that we could do some other surveys to gather interest and see what the professions would say on this.
I mean, I think data like that never hurts. I guess for me, I wonder if there was other questions we would want to ask besides that one as well, including, are you in favor of a provisional license for other bachelor's level folks, kind of thing. Well, I mean, I'm hearing strong, consensus for at least trying to do this. And I think this could be something that we could also discuss in our future meetings, because as we're looking at opening up or adding to the statutes and regulations for counselor requirements, this would be right in there. Thanks for your persistence, Christina.
Of course.
Definitely think in the field, and we've been hiring for a counselor for a long time. And so because we have a counselor, sometimes I find that I'm stuck with not so quality counselors. I definitely think opening up the field, there are people that can do this, and just because they're from a different background does not mean that they can't, learn the addictions courses and kind of learn how to pull this population. I definitely think that we need more availability, because even counselor, like the counselor I have right now, she's a good counselor, but she's terrible at her paperwork. So there's lots of different areas that have strengths in, but I don't know. I think some options, and I also think that the diversity topic is very good too. I think that that's also needed. Filled addictions does not discriminate. So the type of population we're going to be working with is just going to be all of different people. And I think the more education that we have, the better off, our clients will be. So
yep.
I am definitely in agreement that if we need more meetings, then I'm available for that too. So
perfect.
I am on board.
Appreciate that, Charity. Looking ahead on the agenda, I'm seeing that we have a presentation by Cynthia Moreno from, she's with NADAC as well as this accrediting body. Is she available, David?
She's not logged on to the call yet, but
Okay.
I do expect her to log on any minute. Given the number of items that are left on the agenda, I do have one item that I wanted to see if the advisory committee could talk about before that she logs in for the presentation, if that's okay.
Okay.
And it would be under old business, item C, the discussion about changing
Oh, yes, thank you.
recommendation about the educational
Mhm.
requirements. If you want, I can go ahead and share my screen on that and just kind of pull up that regulation. So,
Perfect.
okay. So the advisory committee did talk about this last meeting. And so can you see the copy of KAR 102-7-3?
Yes.
Okay, so at the last meeting, we had a discussion about educational requirements for licensure and noted that a number of the professions under the BSRB have a requirement that a certain amount of education has to be received in residence. And the definition of in residence has a piece that talks about the student being physically present at the academic institution in front of core faculty members and face-to-face contact. This physical presence component is unique, and I've talked to a number of other agencies from other states and most of the professions under the BSRB, and they just don't have that. And for online only programs, there's really no way for them to meet that requirement. So for programs that are not part of a national accrediting body, or for the professions that we don't recognize a national accrediting body, this is really, it can be a limiting factor in terms of who can be licensed. And so some of the other professions had conversations about, would it still meet the public protection mission of the board to remove the piece of that in residence definition that requires to be in the physical location? The social work profession recently voted to remove the physical component. The Marriage and Family Therapy Advisory Committee recently recommended removing the physical component, and the Professional Counseling Advisory Committee had identified it and asked for some language to be brought back, but they basically had said that they are ready to take a vote on that issue as well. And so at the last meeting for the Addiction Counseling Advisory Committee, they asked for the language to be brought back about potentially how it could look if you just removed the physical presence component from the definition. So what I did here is in KAR 102-7-3, if you look at the definition of in residence that you can see right here, it basically, if you wanted to just take out the requirement about being in the same physical location, then it would say in residence when used to describe a student means that the student and one or more core faculty members, adjunct faculty members, or agency internship supervisors are in face-to-face contact. And then there was a request last time to make sure that face-to-face contact would be interpreted as either in person or by screen. And so we talked about that we had changed the definition of face-to-face contact to clarify that it could be by screen or in person in regards to some of the supervision regulations. So after this face-to-face contact, you could take a look at the top of the screen and see that you could continue on with that language and say either in person or by synchronous video teleconferencing. And so if you did it that way, it would remove just the requirement of being in the physical presence of the institution, but it would still require the core faculty ratio being in face-to-face contact, but it would just allow it to be by screen or in person as well. So just want to bring this back for your consideration and see if your advisory committee was interested in making a recommendation to make that type of change.
Well, considering our conversation last time, which was fairly positive, I'd entertain a motion.
I move that we accept this as presented in.
I would second that motion.
Any further discussion? All in favor, say aye.
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 Any opposed? Excellent. Very good work. Hey, did she log on yet, David?
No, I have not seen her log on yet.
How does the committee feel about a 5-minute break? All right.
That sounds great.
So what do you want us to do, David? Just
I'll go ahead and put you into the waiting room, and then we can plan to reconvene the meeting at 12:38.
yes, works for me. Thank you. Well, it looks like everybody's back.
And Deb, I have sent a message to Cynthia as well as Jerry, because they have not logged into the Zoom meeting. But it's possible that a conflict came up for them, so.
Oh, sure. Well, we can always do that next time.
Why is my speaker not working?
We can hear you, Charity.
Okay, well, we will just.
I'm on a BSRB advisory.
I just went ahead and muted Charity.
Okay, thank you. We'll just march along. I have a hard stop at 1, so just to put that out there. All right, I think we are ready to take up continued discussion on possible changes to unprofessional conduct regulations 102711 and 102711A. And we had quite a bit of discussion last time. I thought made some good progress. Were you
Yes.
gonna-
And Deb, there was one item that the advisory committee discussed. It had to do with some of the other professions. So in terms of convictions, there are two items that come up for a lot of the unprofessional conduct regulations for other professions. One of them is conviction of a crime related to the professional practice in those different areas. And pretty much uniformly across the professions, that's included as something that would be unprofessional conduct. The other item, and it appears to be missing from the Addiction Counseling Advisory Committee or the Addiction Counseling Unprofessional Conduct Regulations, is basically a requirement to notify the board upon conviction of certain crimes. And I mentioned during the last meeting that some of the professions talk about failing to notify the board of conviction of a felony, whereas other advisory or other professions have it just as a failure to notify the board about conviction of a crime. And so I mentioned that I was going to bring back some information about the different professions. So in looking at those professions, it appears that licensed psychology and social work indicate that it would be unprofessional conduct to fail to notify the board about a felony. So those two professions have that, but most of the other professions talk about it would be unprofessional conduct to fail to notify the board about a conviction of a crime. So currently the addiction counseling profession doesn't have that specifically listed in unprofessional conduct regulations, but I think for consistency, it would be helpful to go ahead and add one of the two, so that would be more in line with the other professions.
Well, given that, I mean, not that we're unique in this way, certainly, but as I think about some of the cases that we review and things like that, DUIs, that's not always a felony, of course. So to me, it should be any crime, but I'll hear other folks' thoughts on that. I mean, it doesn't mean we'll do something about it, right? Just because they report it.
Correct. Yes, there's the issue of conviction of certain crimes can be a limitation on your ability to get licensed in Kansas. But failing to notify the board that you were convicted of a crime, it's that failure to notify a piece that is an unprofessional conduct in a lot of the other professions. So
I think all would just make it simpler, right? That then you don't have to think, oh, is this one that fits or doesn't fit? And then, make an error in failing to notify because you thought maybe it didn't fit the requirements. Where if we just say all, then you have to notify all the time, and if you don't, it's more clear that it was a violation.
Yeah, and I just had a thought about how often is someone arrested maybe for a felony, but they plead down to misdemeanor. And so again, I just think we want to know those things. Any counter argument? Hearing none, do I have a motion to adopt the language of it's unprofessional conduct not to report any conviction of any crime?
right, we failure to notify the board of that.
Yeah.
I would make that motion.
Is there a second?
I'll second it.
All in favor, say aye.
Aye.
Aye. Was there any opposed? Good, thank you. What else do we have, David?
So on that topic, if there were any other items individuals had, they wanted to bring back on the unprofessional conduct regulations, we could discuss that. If there are no other recommendations, then we could go ahead and move to the next item on the agenda.
Okay. Discussion on unprofessional conduct regulations for care of clients in crisis. So we discussed this at the full board meeting. The gist of the discussion is what is the requirement? I'll call it, what is the standard of practice that we expect from probably folks mostly in private practice, but it could be agencies, in terms of caring for their clients when, or making arrangements to care for their clients when they are not available, like on vacation or something. So what do you guys think? What's expected? What should we do? Because there's
I can tell
concerns.
you,
Go ahead.
I can tell you what it looks like. I mean, right now, that if a counselor is going to be out on vacation, that counselor might mention that during sessions because they're meeting with the patients all the time, but the supervisor is making sure there's coverage that happens for that week. So we ensure that what the patient expects to receive is available in the same fashion. Now, if that counselor's out because they're ill or out because they plan to be out for a week, I don't know, as far as the formalized letting all the patients know the counselor won't be there. I'm not saying that's good or bad. I'm just kind of speaking to what I believe happens right now in our setting. So I believe that's what happens now.
So if a client needs some assistance, some, I don't know, behavioral health assistance from your agency at 2 a.m., what happens?
Yeah, it'd be the same thing we have now. So we do have a phone number that rings 24/7 to residential. Of course, if it's an emergency, call the hospital and, get medical care. Outside of that, when we have staff available, peer mentors often provide support to patients. If the counselor is not available, just regardless, even if the counselor is in that day and they're not available, peer mentors are available for support. So it falls into that, what we typically have still exists when that counselor is not in the office, versus maybe a more sophisticated process that a mental health center has, et cetera, for 24/7 crisis calls, et cetera. We don't necessarily have that anyways.
I guess that's my question. I'm not trying to be difficult, but when we say crisis, are we talking how would we define that? Because if we're saying a behavioral health crisis, there are mechanisms, 988, there are crisis safety nets in every community. But I guess how you define that in relative to substance use disorder treatment, perhaps.
Well, and I think, some of the conversation at the board meeting on this topic, and I'll go ahead and kind of filter this through the unprofessional conduct regulations for the addiction counseling profession. So if you look at item JJ, I think this is probably the closest unprofessional conduct regulation that can tie into this conversation. It would say that it's unprofessional conduct to essentially fail to seek continuation of service or abandoning or neglecting a client under or in need of professional care without making reasonable arrangements for that care. So kind of along the lines you were talking about in terms of the 988 National Suicide Prevention Hotline rollout, is it sufficient to go ahead and put down that if you're not able to reach us, you should call 988? Or do you need to have a more formal arrangement established for someone who would be able to assist your clients when they are in need of crisis services or in need of care? And so I guess one of the questions is should there be a more formal type of, should language be adjusted on this topic? Does this unprofessional conduct regulation need to be adjusted for that type of a conversation? I think as well as I can tie it to our unprofessional conduct regulations, I think this one may be the one that's the most on point in terms of this conversation. But
it really comes down to I'm just, I think what's interesting is to just have these conversations in this group about, the heart of it for me is reasonable arrangements. So what is our collective thoughts on what that looks like?
Well, and it's interesting, Deb, because as I read that, what first came to my mind is not necessarily crisis, but just professional care. Neglecting a client under in need of professional care without making reasonable arrangements for that care you could interpret that to include everything from behavioral, mental health services, medical care, not necessarily crisis based, but just continuation of care in general in the day to day. And I don't know if, again, I'm just overthinking this, or again, if to me that is an issue, if that needs to be more specific as an additional to crisis type, appropriate plans of care have been identified and reviewed with the client in regards to crisis. Because to me, those are two different things, just their continuation of service. What sort of things do they need to really address fully the issues that they're facing in their care versus crisis? To me, those are kind of two different.
Well, the context it was more in terms of after hours crisis.
Okay.
That was the context in which it was brought forward. I mean, I would hope that if you truly had true abandonment, right, and there was a complaint, that statute would allow us to, make a finding if there was one that they failed to meet that.
The more of a broad.
I think the better example is outpatient private practice. I have a shingle. I work out of my house. I do services, because that's the thing now. I mean, I don't, but if I did, and I needed to go on vacation, is it sufficient for me to say, here, if you're in trouble, if you need help, call 988? Or is that in some way some sort of abandonment? Or do we expect people in private practice to contract with somebody or just make some sort of, reciprocal arrangement that we're going to cover each other when we're not there?
Since you just had the KDAD licensure stuff up, I think that there is a requirement about this in there that I wonder what it said, but I do believe it is, because I remember, when we implemented those a long time ago.
Thank you for reminding me that facility licensure is part of this world and not necessarily the rest of the world. So thank you.
That was a requirement, that there be some kind of emergency things. So I would just say maybe we want to look at what that says and not be something that would contradict.
Was 988 deemed appropriate was the CCBHC model when this came up about after hours calls, et cetera? I feel like it was brought up recently as this connects to that type of scenario. I don't remember.
I don't know the answer.
I feel like there's a conversation recently about like after hours calls and coverage and what could be utilized at 988 was something that fit into that conversation. It's definitely something that's good and new, and we wouldn't have had that to talk about a year ago. So it's part of the conversation.
Well, and honestly, this issue first came up 5 years ago. And so we didn't have 988. What we had was the safety net of the community mental health system. So is it appropriate for an LSCSW in private practice to say, hi, clients, I'm going on vacation. If you have any mental health crises while I'm gone, call your community mental health center?
And I think there's an equivalency thing here too, because when the private practice clinician is in the office, they're still not doing 24/7 crisis calls and coverage. So it should be equivalent to what they offer when they are available versus when they're not. But neither of those things have included. I don't think most private practices are having like after hours crisis call lines. They probably rely on ED, mental health center, 988. So I think it should just be equivalent to what they could offer when they are in the office.
I would agree, Shane.
So that reasonable language, that piece, that makes sense to me, just partly because where you work may make a difference on what's reasonably accessible as well. I know when I was in private practice, we did have the, crisis component. And if I wasn't working, there was a crisis line, there was a crisis number. And I know some of the agencies, some of the private practices will contract out to the folks that triage it and then get it to whoever is particularly on call, that kind of stuff. So there are methods and ways to do it. But to what extent might make a difference on where you're located as well. And I don't know if 988 is sufficient or not. That's an interesting question.
You're gonna get into all kinds of things with that, like
Yeah,
access to
so-
care across the state.
Yeah,
We're not going to solve all the things for sure, but I mean, being aware of there's a difference between this community to the next one on what we can expect of them reasonably. It's true.
Well, ultimately, even with 988, they're going to, if it comes down to, they're going to contact the safety net provider in that community, wherever the client is, and that would be the CMHCs. Yeah, I mean, it all cycles back, and I think Shay made a good point. It's what is the standard of care right now if someone's in private practice, whether they are on vacation or not, are they providing those things? And generally, right or not, it will fall to the community-based provider in the area, the safety net providers in those counties, wherever the person is.
I think you would have to require them, whatever. Yeah, you'd have to require private practice to set those things up in general when they are in the office in order to expect them to then have those things when they're not in the office. So that lead into a bigger conversation if we expected those things from maybe that example of private practice.
That's a good point. It's a really good point. So I'm not really hearing that we need to change anything. At least not for our discipline. With perhaps a little bit of cover for KDAD's facility licensing. We can look at that and bring that back next time. Anybody feel different? Good discussion. Well, I see that we're at the end of our business. It says next meeting Friday, December 16th, but I think we're going to try to meet sooner than that. So what do you all, I'm thinking October meeting and November meeting and potentially December. We can always cancel December if we don't need it. Does that sound good?
Sounds good.
Do Fridays tend to work for people
Yes.
Yeah.
like this time frame?
Yes.
so they're fine for me on Fridays as long as it's after, like 11 o'clock and after, unless you decide we have to go back in person. And if that happens, then we got to.
No, I don't see us deciding that.
Yeah. Yeah, I was gonna say I can't do 10 minutes to Topeka from here. Just not gonna happen. So
I understand. All right. Good work, everyone. Appreciate everyone's help, and David will send something out and we'll figure out our next meeting.
We should probably let Jason know that it was a really good meeting and he didn't help with these things. So
Well, I
Send him a
did
note.
text him and told him that we would be meeting more frequently, and I got the thumbs up. So
yeah, nice.
Very good.
Will that be noted in the meeting notes that Shane mentioned that for Jason?
I think it's important for Jason to see that.
I think it is too. I think it should be noted.
Oh, I think that's great. Awesome. Well, you all have a great weekend.
You too.
Thanks, you too.
yeah.
You
Bye.
too. Thanks for everything, Deb.
Sure.
Bye.
Bye-bye.